Hello, this is Module 4, Musculoskeletal System, or what we might call MedSurg Part 1. Common orthopedic conditions, which are acute, which are fractures, low back pain, which can be acute and chronic, sprains, strains, or osteomyelitis. Fractures, I like you to see that there are many different kinds of fractures. There's closed simple, which is not poking through the skin, but broken through and through. There's green stick, which is sort of not broken all the way through, usually happens in younger people who have less rigid bones. There's open fracture, which you would be able to see via a laceration. Depressed, which means it's pushed in, often found on skull fractures. Comminuted, which means it's not together whatsoever. Low back pain. Let's go over one of the most common injuries. The pain can result from one episode or, more commonly, repeated episodes of stress to the back. Often people think it's one big thing that puts their back out, but studies have shown that it's often repeated small injuries over time. That's why nurses have such a high back injury rate, is because over the years they've lifted so many patients, sometimes not using the best technique. Risk factors are often most related to deconditioning and poor overall health. So smoking, poor body mechanics, degenerative joint disease, poor muscle tone, lack of exercise, and then the people that go out and do things on the weekend after they haven't working, they didn't work out for years, they don't exercise, and they go out one weekend and play football. Oftentimes they get hurt. Chronic musculoskeletal conditions, club foot, degenerative joint disease, curvature of the spine, muscular dystrophy, osteoporosis, osteomyelitis, and osteoarthritis. This is a picture of kyphosis. People often consider that humpback. That would be the lay term. Lordosis, which is often referred to as swayback. And scoliosis, which is a curvature of the spine. This one you can see from this Wikipedia picture is a pretty intense curvature. Sometimes they are quite small and unnoticeable. Osteoporosis, low bone mass and deterioration of bone tissue. Bones become weak and easily fractured. For increased risk is people with low intake of calcium, family history, female, postmenopause related to low estrogen females or low testosterone males, chronic steroid use, and sedentary lifestyle. Osteoporosis for therapeutic management is to take adequate amounts of calcium in a diet, including green leafy vegetables, salmon, dairy products. There's a lot of things besides milk that have dairy. Calcium supplements, limit the alcohol and caffeine intake, stop smoking, do weight-bearing exercises, and medications, which is estrogen replacement therapy. Osteoporosis diagnosis, DEXA scan or a QUS, which is a qualitative ultrasound of the heel, or the diagnosis test. Osteoporosis therapeutic management, replace estrogen or testosterone. The medications are Avista, Fosamax, Actonel, miacalcin, sodium fluoride. Nursing care is to treat symptoms. It's often very painful. Ensure safety, fall prevention. Falls can result in broken bones very easily. Exercise, range of motion, education. Osteomyelitis, acute or chronic infection of the bone. Think of the signs and symptoms of an infection: redness, edema, warmth, itchy, draining. That's what you're going to see. Must be aggressively treated because bone has very little vascular supply, so it can easily become infected, and that infection is hard to eradicate. It's diagnosed with bone scan, MRI, CT, wound culture, and often by elevated white blood cell counts. Therapeutic management is surgical debridement. It's the primary treatment. Postoperative care and continued wound irrigation, strict sterile technique. You need to monitor the signs for infection, monitor temperature and white blood cell counts. Most cases are caused by Staph aureus, which is a very common bacteria. IV antibiotics based on wound blood cultures for 4 to 6 weeks, or it's often necessary to do a hyperbaric oxygen therapy to promote healing. Osteoarthritis, clinical manifestations. So crepitus, which is a grating sensation with range of motion. There's a more limited range of motion and pain with movement. There's Herbanism nodules, distal interphalangeal joints, or Bouchard's nodules, which are proximal interphalangeal joints, swollen. There's joint stiffness, and there's muscle atrophy. Therapeutic management is limited exercise program. They have a very difficult time exercising, but a limited exercise program is proven to be effective. Maintain ideal weight so you do not put as much strain on those joints. NSAIDs, heat and cold, and TENS units, which are small amounts of electricity that run through electrodes on your skin to help alleviate pain. Total joint. This is a picture of a total joint and how it looks. A metal rod with a ball is inserted into the bone, and the other one has which is the cup that goes over that ball. These are both metal pieces. They replace both. For the nursing care, when this has been done, is you have to maintain this person in a neutral position. You have to make sure that you prevent any embolus. So as you know, long bone fractures are often the cause of an embolus. Prevent infections. This is a foreign body inserted into your hip, so any infection is very difficult to treat and the hardware would need to be removed, which is a major operation. Assess for bleeding, assess for neurovascular compromise, manage pains, quite painful after surgery for a while, and promote activity to when the physician has ordered it. Total knee, similar to a total hip. Some things that are done are a continuous passive motion device, CPM, to keep that joint moving, fluid. Ice or hot cold machine so that you have a water running through a knee brace, which is either heated or cooled. Keep the knee in the neutral position, no rotation inward or outward. You need to monitor for thromboembolism, infection, bleeding, color, sensation, movement, CSM, and teach no hyperflexation or kneeling for 6 weeks. Internal and external fixation. So the one on the picture of the X-ray on the left, you can see that the devices are inserted into the bone underneath the skin, and the one on the right bottom is external fixation, where the fixation is done outside the skin. T treatments for broken bones: closed reduction, immobilization. There's splinting, there's casting, or there's open reduction. So closed reduction is they can fix the broken bone without opening it up. Closed reduction is, open reduction is they have to open up the wound in order to fix the fracture. Cast care. Some places do in fact still have plaster, so you have to be careful when plaster is wet to prevent indentations. You have to elevate it above the heart for 24 hours to prevent swelling, which often occurs. Range of motion above and below cast. Obviously you can't move the part that's in the cast, but above and below you can. Make sure you air dry that cast. If there is some swelling present, ice is able to reduce that. You also have to look for color, sensation, movement. So let's say you broke your arm and the only thing that was visible were your fingers. You need to check the color, sensation, movement of those fingers as an indicator of any problems neurovascular underneath that cast. And please, no foreign objects put into that cast. Don't stick the pencil in there to scratch. There's many different types of traction. There's Russell's, cervical traction, Thomas Splint, Bryant's, pelvic. Skin traction, which is used only for short term. It's used before surgical repair. It's tape that is pulling on the skin, which helps to align the bones. Often there are small or lightweight pulleys, and it relieves some pain and promotes rest. Bucks traction is basically a boot that traction is put downward. Weights cannot touch the ground, and the patient does have a limited movement because it's only for the broken foot. It's a boot, so you can move your upper body. Skeletal traction, that's long-term use. There's weights of maybe 15 to 30 pounds. Weights also cannot touch the ground because once they touch the ground, then they're no longer exerting any pressure. Make sure the knots are in the most appropriate place. The knots go by the pulleys, so in case accidentally the weights are released, that the rope doesn't fly through the pulleys. You also have to monitor color, sensation, movement. Make sure that pin care is done and skin care. Balance suspension. So this picture shows a balance suspension where you have both forces going towards the foot of the bed and also keeping the leg up. It's a counter traction. Spinal traction. This is more dangerous and has to have more care taken. Make sure that there are knots above the pulleys in case the weights or anything else pulls free, that the rope won't go through the pulleys. Make sure the pin sites are clean. Make sure that they are good pin care is done frequently, and make sure that you get professional help, physical therapy, and doctor's order in order to turn the patient. And also think about how you can make that patient comfortable. Complications of any of these fractures are compartment syndrome, which is when you have a swelling inside of the compartments in the muscles, which put pressure on the vessels and sometimes obstruct blood flow. There's fat embolisms, which can cause strokes, heart attacks. Deep vein thrombosis, which also cause strokes and heart attacks. Osteomyelitis. And aseptic necrosis, which is when the tissue is dying, although it's not dying because of infection, it's just dying because of lack of blood flow. Compartmental syndrome. Prevention is early detection. So check color, sensation, movement. You'll notice that there is a common theme running through all of this. Is frequent checking of color, sensation, and movement. Ice, elevate. If there's a dressing, make sure you loosen that. And they often have to open that cast. If it does not correct the issue, or if the compartment syndrome is severe, often they have to do a fasciotomy, which is just a slice down your arm or wherever the compartment syndrome is to release pressure. It's opening up and leaving an open wound. Fat embolisms, which are frequently caused by long bone fractures. Elderly hip fractures as well. You will be assessing for respiratory distress, petechiae in the trunk. Petechiae are small pinpoint bruising, and prevention is early mobilization of fracture. Deep vein thrombosis, most common complication. Predisposing factors are long bone fractures and not moving and not using any kind of therapeutic response measures such as low molecular heparin or the puff boots, which put pressure on the vessels and prevent thrombus formation. Common sites, leg, pelvic fracture, and it can go to a pulmonary embolism, which this picture on the bottom right indicates. Osteomyelitis, source is open wounds, implanted hardware which get infected. Staph aureus is usually the culprit, and the treatment is IV antibiotics, wound care. Aseptic necrosis, as we were discussing, not caused by infection but lack of blood flow, causes the death of tissue. Often can happen around hip fractures with bone displacement or where hardware interferes with circulation. Amputations, these are frequently because of diabetes or diabetes and smoking. people who have diabetes and get an infected foot ulcer. They're often very difficult to heal. If it becomes osteomyelitis and treatment is not helping, eventually they will have to do amputation. It can also be caused by trauma. Often the person who goes through this grieves the loss of their lost limb. So it's sort of like a person that they're missing and they're grieving for. It causes altered self-concept of who they are, who they think they are. And the nurse has to address coping and family response. And that's all we have for this session. Thank you.